Welcome to UT Brainstorms. My name is Mike Mock. I'm a professor in the Department of Neuroscience at UT Austin. And the Department of Neuroscience sponsors UT Brainstorms as a way for us to share our knowledge and passion about neuroscience and neuroscience research, and to learn from you how neuroscience discoveries affect our daily lives. Always want to start by thanking Elena Silva and Susan Cushman, are the two behind the scenes people that make all of this work. So thank you to them, and to thank you for being here. We're grateful for the continued interest in UT Brainstorms. This is Brainstorms number 43 in our 5th season, and we're grateful for the continued interest. We intend to have a 6th season beginning in the fall, hopefully in person. Either way, every UT Brainstorms will continue to be, the videos will continue to be posted on our YouTube channel, UT Brainstorms. So you can always see them when you miss them. You can see the past ones. You can watch them over and over again. All good stuff. Questions are a really vital aspect of UT Brainstorms. We encourage you to ask as many questions. You have opportunity to get answers from expert neuroscientists. Type them into the YouTube chat, and feel free to start asking questions whenever it occur to them during the presentation. Whenever we have a great panel of experts tonight to help answer them. So with that, let me introduce tonight's speaker, who is Dr. Joshua Chang. Joshua is an MD, PhD, and an assistant professor at the Department of Neurology at the UT Dell Med School. Joshua is an expert on the use of brain stimulation to treat neurological diseases. And in particular, I think he is the world's authority on how the patterns of that stimulation are important. And he's going to talk to us about that tonight. So sit back, fasten your seatbelt. It's going to be a great brainstorms with some neuroscience and some clinical implications. And with that, please help me do that really unsatisfying thing where we virtually welcome tonight's speaker, Dr. Joshua Chang.
Well, thank you very much, Michael, for that introduction. I hope I live up to it. So I'm super excited today. My name is Joshua Chang. I'm super excited today to be able to tell you about the electrified brain and just how electricity is being used now to treat neurological disorders. Now, when we think about treatments in medicine, especially, we often think about pharmaceuticals. So we think about drugs, we think about pills, elixirs that we're going to be taking, for instance. And the reason why we usually think about these things is because we have a really good understanding of the biomechanical or biomolecular functions of what's going on in the body. So for instance, if we are worried about neurotransmitters at a synapse, like you're seeing here in this image, drugs are developed specifically to design and designed in such a way to inhibit transport reuptake, for instance, of these neurotransmitters. Or if we need to stimulate a receptor that isn't as functional, then we might, again, create a chemical compound to adjust and correct for these chemical imbalances that are going on in the body. And so the majority of medicine, when we think about it, are often in terms of these concepts of pharmaceuticals. But I want to talk a little bit about the idea of electricity now being medicine. And this is something that isn't a new concept. In fact, it's a really old concept. There's some historians that suspect that the Egyptians in back in ancient Egypt, around 2500 to 3000 BC, were using electric catfish to heal headaches and heal pains. But the first recorded history of this was actually in 47 AD by Scribonius Largus. He was a court physician to the emperor, the Roman Emperor Claudius at that time. And he told this really interesting story of this man named Anteros, who was a freedman of Nero at the time, who was walking along a beach. Now, we all like to, long walks on the beach is something that we commonly joke about enjoying. This guy really enjoyed it because in this one instance where he was walking along the beach, he accidentally stepped on a live electric ray. Now, just to give you a little bit of history, Anteros had gout or some kind of arthritic pain. And when he stepped on this electric ray, the pain disappeared. When he got shocked, the pain disappeared. And this was recorded by Scribonius Largus, and this is again the first recording of it in 47 AD, and his works, The Composition. Now, Scribonius Largus continued to think about this and work on it, and he wrote in his compositions that a live stingray placed on that part of the head which is in pain until the pain stops and the part goes numb immediately relieves and perpetually cures headaches. So I'm not sure who was the unlucky subject, or maybe the lucky subject that was the first test of this. But Scribonius Largus saw over time that you could indeed stick a live electric ray on someone's head and cure them of their headaches. Now, about 100 years later, Claudius Galen, one of the foremost physicians and philosophers of antiquity, also discusses the use of these torpedo fish or electric eels to accomplish the same things. Now we fast forward about 1500 years, about through the Middle Ages, and this is kind of the technology at that time, the capture and use of live electric fish or eels. There's a term called electroichthyotherapy. And at that point, electricity was only generated naturally through these animals. Come the 18th century, we started being able to develop artificial electric generation at that time. And as you know, we're all aware of the story of Benjamin Franklin being really fascinated with electricity, and flying the kite, for instance, in a lightning storm. He actually then started working on this idea of washing people with electric charge. And this was the idea of an electric bath. And people called it actually Franklinization. And this was where you would have charge just kind of flowing through people. And the idea was that it would then be able to heal and relieve people of a lot of different ailments or disorders. It didn't work very well at the time. There was a lot of, it came to be known kind of as something that only charlatans or quacks used. But there were some people that very systematically tried to determine which disorders and diseases worked well and which didn't. And actually, there's a lot of really interesting literature that shows that in the field of dentistry, electrotherapy was used specifically in the gums to anesthetize the pain as people were extracted, as the dentist would extract their teeth. There are recorded histories and lots of logs about how long to stimulate for, what kind of stimulation, how strong the stimulation should be, and how you kind of optimize that treatment specifically for each individual. But at that time, again, we didn't have a lot of control over what that stimulation looked like. It was a very crude method. And now come around the 1930s, 1940s, around the time of the World Wars, a lot of advancement was happening in the field of electrical circuitry. Advanced circuit designs were being developed, and further fine-tuning and control of what that stimulus or what those electrical signals could look like were pushed forward and advanced even further. And so around this time, the idea of electroconvulsive therapy, cardio defibrillators, cardiac cardioverters, all of these ideas were developed and built, and the beginnings of these technologies were constructed around this time frame. Now, these are still used today in practice. We still have electroconvulsive therapy for psychiatric disorders that are resistant to drugs, and we're still using pacemakers and defibrillators today, very, very commonly in clinical practice. Now, moving even more in the last couple of decades, and very more recently, we're starting to see even further development and use of electricity as a therapeutic in more fields and more areas. We're starting to see deep brain stimulators being FDA approved for Parkinson's disease, for epilepsy. There are spinal cord stimulators that are being developed for people with chronic back pain. And all of these areas kind of are being encompassed in this term called electroceuticals. And so this is a play off the word of pharmaceuticals, but instead of pharmacological treatments or biochemical treatments, we're using therapies that use electrical impulses. And so the idea is, by shocking some part of the body, whether it's the brain or another organ, can we correct for these pathological behaviors that's going on? And there's a lot of research going on into this area now. There are devices that are being tested right now in early phase trials for treating migraines. I mentioned arrhythmias, heart failures is fairly well known. There's work done on the phrenic nerve for the diaphragm and hypertension. There's even some really interesting work done outside of neurology now where they're looking at, can we stimulate the thymus to try to prevent or reduce or suppress autoimmune disorders? And so can we prevent the immune system from attacking cells? So for patients with rheumatoid arthritis, for instance, that aren't responding well to drugs, are there ways that we can actually stimulate the different organs with electricity in order to correct for some of these behaviors? So this is a really long history that we have, dating all the way back from about 2500 BC to now. And really, kind of the questions that we're still struggling with are, number one, how does this work? With pharmacological therapies, we have a pretty good idea that this particular compound interacts with this particular receptor, or it interacts with the organ system this way, or it's a analog of something that's natural in the body. With electrical therapy, we don't have really good ideas still how that all works and what are some of the rules when we want to optimize these treatments. And so these are the two areas that I'm going to talk about today. We're going to cover what are some of the mechanisms of actions to better understand why, just to conceptualize why it works. And then the second piece, how do we optimize this for practical patient use? So let me start off with just what are the mechanisms of actions. And I'm going to go on a very conceptual level, but the body is filled with what we call switches. And so whether you're talking about the molecular level or the cellular level network, or even the whole organisms, there are pieces of these systems that exist in one of two states or one of a set number of discrete states. So for instance, if we're talking about cell biology, we have cells that are either in a quiescent state, meaning that they're not replicating over and over again. Then they're kind of dormant. But then there might be something that triggers it to then jump into a replication phase. We see this in neuronal networks, for instance, when you might have a neuron that's normally sitting still, or what we call quiescent, but then it'll then start firing an action potential if it's being triggered by some kind of stimulation. And even just as an entire person, we go between sleep and wake states, right? So where we might be in a sleeping state, and then when an alarm or something, a cry in the night comes, then that stimulus will then cause us to wake. And so the body exists often between these two states, and there are switches that allow you to navigate from one state to another state. Now, we're going to talk predominantly about the nervous system. And so I'm just going to do a little bit of background here. Neurons are electrical by nature. And so at the very fundamental unit, the single neuron, we can see that if we zoom into the membrane, just that little piece there, we can see that there are a bunch of these channels in the membrane. And what these channels do is they allow ions to traverse into and out of the cell. Now, I'm going to talk about these two in particular, sodium and potassium. These are the two main ions, but there are many other ions as well, calcium, chloride. There are other ions, but these two play a fairly big role in the transmission of information from one neuron to the next neuron. Sodium, as you can see here, flow from outside the cell into the cell, and then potassium flows from inside the cell to outside the cell, generally speaking. And what happens is when you have these cells, they start off not doing anything at their resting membrane voltage. If you were to put a electrode outside and inside and measure the difference in voltage, that would be the voltage membrane potential of the cell. And so when you give a stimulus, that cell then would react to that stimulus. It'll then increase the voltage. And then once it crosses a certain threshold, it'll fire what is known as an action potential. And what happens is that essentially the sodium channel opens up first, and it opens up really quickly. And as it lets in all these positive charged ions into the neuron, the voltage membrane potential then increases. At the same time, shortly, a little bit later, potassium will then open, and potassium takes a little bit longer to close. And so potassium, as the positive charges are flowing out of the neuron, then starts bringing the cell back to resting membrane potential and even hyperpolarizes a little bit more. And so this action potential here is the fundamental unit of information in the nervous system. And so when we think about, for instance, in signals for computers, we're thinking zeros and ones. in the body, in the nervous system specifically, we're thinking about action potentials and the timing of these action potentials. Now, what's interesting is that even in a single cell, you can have these oscillations go between distinct states. And so a lot of our understanding of the action potential and these neurons come from the work of Hodgkin and Huxley. These are two mathematician physicists, again, around the turn of World War II, who looked at the giant squid, or who looked at the squid. And the squids have a giant axon that kind of traverse down the body. And when they're needing to run away, a single action potential goes down and then causes contractions, which allows the squid then to move very quickly away from danger or wherever they're wherever they are at that moment. And so here's a recording of one of these squid axons, and you can see the environment of the squid axon can be constructed in such a way where it exists between one of two states. Either the state where nothing is happening, as you see in the first half, and then a state where it's repetitively firing action potentials over and over again. And to transition between these two states, a single pulse was necessary. And that single pulse then could take the squid axon from one state to another state. Now, this is just on the level of one cell, but realistically, this happens at the entire, at different levels as well, and for different organs. If we think about in the heart again, when someone it goes into some kind of cardiac arrhythmia, whether it's ventricular fibrillation or supraventricular tachycardia, or whenever their heart is not beating normally, there are specific instances where by giving them a shock, we're able to then return them back into normal rhythm, normal cardiac rhythms. Similarly, for patients with Parkinson's disease, deep brain stimulation can stimulate the subthalamic nucleus in the brain, and that will then cause their tremors to turn off. We also, again, like I said, FDA has approved devices to be placed in the cortex or the surface of the brain to reduce epileptic seizures. And as I showed earlier, the trigeminal nerve is an area of research for suppressing migraine behavior as well. And so this idea that systems can exist in these discrete states and electricity can be used to kind of turn the switch on and off is the fundamental mechanism of action that's being exploited by electricity. Now, so this then leads to the question, okay, well, if I can just give a pulse, how big of a pulse do I give it? Do I give the system? And this leads to the question of how do we then optimally dose these treatments or therapies? So here is that cell, this is the squid axon again. And in the same paper, what they did was they actually started then giving noise to the system. And as you can see here, the amplitude of the noise is smaller than the amplitude of the single pulse. And what they found is that by giving noise, they were able to have the system switch back and forth between the repetitively firing state and the quiescent state. And so this leads to the question, well, okay, so maybe you don't need a pulse that big. Maybe you can do something smaller, a little bit softer, to cause these pathological oscillations, or like say, for instance, repetitive firing. What if you could turn them off with something that looks like this noise? What about this noise is actually turning it off or turning it on? And so this idea that actually a lot of the pathologies in the brain or a lot of the disorders in the brain are due to oscillations is something that is being studied and has been seen. Again, like I've said, epilepsy, Parkinson's, there's this idea that there's an abnormal pattern that's going on in the brain. And if we can then turn it off or stop it from kind of firing over and over again, we may be able to then correct that aberrant behavior. Same thing for the heart as well. And so just to kind of draw this picture here, if we imagine state 1 as our pathological behavior and state 2 as the healthy normal behavior that we want to get to, ultimately, we want to move in this direction. And there are a number, as we saw from the noise, there are a number of potential signals or stimulus shapes that could get us from state 1 to state 2. But at the same time, there's a very large number of them that might actually not do anything and not benefit the patient in any way. And so what we're really trying to do is kind of play Goldilocks here. We don't want something that's too weak, which then essentially doesn't do anything for the patient. But on the other hand, we don't want something too strong either for the patient, right? If it's too strong, especially if we're talking about the nervous system, this can cause off-target effects, meaning that although we're stimulating, say, for instance, the subthalamic nucleus, we might be then accidentally stimulating some of the neighboring structures, causing adverse effects or some of the side effects that patients experience. Furthermore, if we stimulate it, too large, there's a potential that we're actually going to burn out the tissue itself. We are injecting a bunch of charged ions, charged electrons into the tissue, and so that could also have a negative effect on the tissue itself. And finally, even if it wasn't hurting the patient necessarily, the fact that we're using the battery life of these devices, especially the implantable devices, at a much higher rate than we need to, means that then there would be more surgeries or more procedures that would be necessary to then replace the battery, which then increases the mortality and morbidity risk for a lot of these individuals. And especially given that a lot of these patients that are at a point where they're not responding to drugs and they're not responding to normal therapies and need electrical therapies, a lot of these patients are also at a more frail state. And so having those surgical procedures just increases the risk of adverse events happening to them. So we're really looking for something that's just right. And so what I'm going to do is I'm going to take epilepsy just as a case example. If you're interested in epilepsy, Dr. Liberty Hamilton gave a really good talk a few months ago. I want to kind of on epilepsy specifically. I'm going to kind of give a very high level portion here, but epilepsy has pretty high prevalence: 2.3 million adults, over 450,000 children, about 150,000 new cases, and it's a huge financial burden. It's very likely that almost all of us will know someone that has had some kind of epileptic event, or has epilepsy, or may have a seizure event in the future. And traditionally, the normal treatments for epilepsy are pharmacological. About 70% of patients respond well to pharmacological therapies, but there is about 30%, even with developments of new drugs, that are still not responding well. Now, surgery is an option for a lot of these individuals, but again, like I said earlier, because a lot of these patients are more frail or more vulnerable, surgery is a really big step to take. And so there's been a lot of interest in using electrical stimulation to more finely stimulate the needed areas without having to put them under for surgery. Now, one of the hypotheses for epilepsy is that when someone has a seizure, a lot of the neurons become synchronized together, and then they start oscillating at the same frequencies. And so here's a picture of an EEG of someone that is having a seizure event. And as you can see here on a number of the leads, you have these correlated events here, right? Where this section here looks a lot like this section here. These signals look very similar to each other. And so there's a synchronization that's happening in the brain across these different regions. And so there's this idea that with these synchronizations, can we then desynchronize or separate out these signals by stimulating them? And so here we have a network of neurons. This is just a cartoon model here, but if we had, say, 5 neurons that are coupled together, they're going to start, when there's a seizure event, they start beating together. They start acting very synchronized, in a synchronized way. And by stimulating it, by sending a shock, then the question is, can we cause it to disperse and desynchronize the activity that's going on here? And all of this is done in a feedback system. So we have a patient where we're measuring data, we're capturing information about them through EEG signals or through other sensors. That's being passed through an optimization algorithm that's determining then what is the appropriate stimulus to give to the patient. And it's this feedback cycle that is being explored now to try to see, can we not be giving patients stimulation all the time, but only when they need it. And so this is, there's a company called Neurocase that has developed something like this, where, as you see here, they're monitoring the signals from the brain. And when they detect the oscillations getting bigger, which is one indication of synchronization, then they'll give a stimulus here, 5 rectangular pulses. And then that will suppress the seizure activity, and then the patient can go back to normal life. And this has you see some really interesting results using this method here. So here's an example from NeuroBase where, as you can see here again, you've got seizure activity across the leads, and when the electrostimulation happens, very quickly the seizure stops. And so you see here again this idea that there is a switch that's happening, and we're activating the switch or deactivating the switch to go from epileptic activity to normal, healthy activity. Now, what's kind of still a little bit of challenge with even these kinds of devices today are that the efficacy is about 50%. It works about half the time. There are still off-target effects, and battery life is still an issue. You need to replace the battery. Last I checked, it was about 3 to 5 years, depending on how often these things are happening and how often, how many bursts of stimuli is necessary. And so one of the challenges and one of the really interesting questions that Dr. David Pedafar, who's the chair of neurology, and I have been working on is, how do we optimize these stimulus waveforms? And so we started looking at search algorithms. And so here again is our model. And using very traditional techniques, we would then put mathematical equations around this and solve it. But as many of you probably are aware, we can't do that for a lot of biology. We don't have the mathematical equations systems to accurately define or predict what's going on in the body. And so one of the things that we've been playing around with is the idea of stochastically doing this. So let's say we put a black box around it and we put 2 electrodes into this system. So we can feed input in and we can measure output that's coming out. And then can we use a stochastic search algorithm, any one of these genetic algorithms, to learn more about what features are actively giving us good results and what are giving us poor results. And then by doing this over and over again in an iterative fashion, can we slowly optimize the stimulus so that it's not using too much energy, but still achieving the outcomes we desire? And so this is just an example of how this algorithm works. Here in the top left, what I'm going to show you is the stimulus. We're starting off with randomly generated stimulation. And as you can see here in the bottom left, this is the system's response to that stimulus. And so here we can see this stimulus is essentially causing all the neurons to remain synchronized. It's not separating out or desynchronizing the system at all. This panel over here in the top right is going to show you the amount of energy that's being given. And so we want that value to go down as much as possible. And then here in the bottom right, what we're showing is the mean field potential. This is just one metric of synchronization that we're using. And so again, here, we want that to go down as well. And so we're really optimizing across 2 constraints right here. We're trying to minimize the energy while also minimizing the synchronization that's occurring between the signals. So I'm going to just play this for you and show you what it's doing. As you can see here, it's fairly quickly starting to separate out these signals, starting to desynchronize it a little bit. And as it continues to search further and further, what it finds is that there is yet another way to do it. That you can modify the waveform a little bit more and get even better desynchronization. And so this method that we've developed, now it is doing it at a cost here, right? So it's requiring a little bit more energy, but it's able to get that extra desynchronization occurring. And so all of this is done in a computer simulation right now, but this is where, as we better understand these tools, can we apply this now in a patient? And so perhaps from a clinical perspective, you don't need that extra level of desynchronization to get this. And so maybe being in this part here, where you have some desynchronization, but you're minimizing energy is sufficiently good for the patient. And so this is something that, although we're understanding the techniques to do this right now, being able to couple that with what's happening in clinical practice is going to be really exciting. Now, just to give you a little bit of information as well, this optimized waveform here uses a lot less energy than the best rectangular pulse waveform that we found. And as I showed earlier, rectangular waveforms are still kind of the mainstay of most devices today. And so one of the hypotheses that we're exploring is this idea that by moving away from rectangular waveforms, can we minimize the energy necessary to achieve the same level of outcome for our patients? Now, this is, as I said, this is just one model that's out there for epilepsy. We wanted to look at a few more models because there are different hypotheses out there as to why epilepsy is, how epilepsy works. And so as I showed you here, this is the desynchronization. We looked at single cells that can have seizure-like activity. And so seizure-like activity, again, you have this repetitive bursting behavior, and we want to suppress that. And then also looking at populations, we found a population model that looked at a lot of neurons in different parts of the brain and how they communicate and connect with each other. And we did the same thing. We ran in our algorithm on these 3 different models. And what we found when we looked at each of these is that there's a very specific time that the pulse needs to be given in order to cause the state transition. As you can see here, these pulses look like they're kind of mirrored images of the signals themselves. And as we were thinking about it and analyzing this a little bit more, we realized that this is really part of a bigger picture of what's going on with pathological oscillations. If you want to turn off an oscillation, oftentimes there is what we're calling a counterbalancing mechanism that's in play. And so here, if you have your system response and it's oscillating, in the red here, by giving a stimulus, which is in blue, a signal that's kind of opposing the system's response, then you can slowly suppress in a very gentle way the pathological oscillation that's going on. So just as an example, having kids on the swings, not to say that kids are pathological, but when they're swinging, for instance, just from experience, we can grab the chain and have them stop really hard by applying the exact opposite force to whatever they're swinging at. But it'll be a very sudden stop, and it would be a very violent stop, right? The child might no longer want to ride swings with you anymore. But instead, if you slowly applied an opposing force as they're coming down, you can, in a much more gentler way, slow down the swing and then bring them to a stop. And so this is why timing is important, right? Because if you're off, if for instance, this negative portion of the stimulus comes at the wrong time, you may potentially exacerbate the system and kind of cause worse seizures or worse oscillations to occur. And this is actually something that is being seen in the literature. This was in 2002, specifically looking at after discharges or seizure-like activity. And what they found is that depending on what time the stimulus is being given, sometimes you'll have 70% success, other times you'll have 10% success. And this is, again, the phase dependency of when the stimulus is being given. More recently, for deep brain stimulation, the same thing is being found, with phase-specific deep brain stimulation being required in order to maximize efficacy for a lot of these patients. And so the idea with precise timing is critical to all of this, right? Like, just like in ancient times when we were looking at slings, for instance, you have to time when you're going to be letting go of this thing so that you have your most effective, the projectile is moving most effectively. And so in the same way, when we're thinking about pathological oscillations and we want to suppress that behavior, the timing of it is critical. Now, I'm going to show you one more model that we have, and we're taking this model from the heart. And part of that reason is because the heart has been fairly well studied, and we have some nice models of how space in the heart is actually also contributing to this. So if we think about cardioversion, right, and if someone has abnormal EKG readings, here we see an example that if someone is in ventricular supraventricular tachycardia, the heart is beating at a very fast rate. When the stimulus is being given, if it's given at the right time, if it's synchronized with the beating of the heart, then this can put someone back into normal cardiac rhythms. But if you're given it at the wrong time, you can actually then cause the patient to go into ventricular fibrillation, which is an even more dangerous scenario or event. So using what we've shown, we can find a phase-specific way, and this is what is being done in practice today, where understanding what the phase is, you can time the pulse so that we can then minimize downstream effects by synchronizing the pulse with where the heart is. Now, Dr. Pedafar and I, we kind of like to draw or color outside the lines a little bit. So we wondered, can we break this rule? Is it possible to use our algorithms to find solutions that might not be restricted by phase? And so just as a quick illustration, this is a wave that we constructed that's traveling in a circle. And this is an example of what can happen in the heart, for instance, or in the brain. And as you can imagine, our phase now is with respect to where the excitation is on this ring. All right. So if we're going to be giving a stimulus at this far wall over here, depending on where the wave of excitation is, it might or might not suppress that wave. And so we started playing around with this and we started exploring, and we developed we ran our algorithm on this and we optimized it in such a way where we were able to find a stimulus waveform that was able to suppress pathological activity at any point in time. So this is what we're calling phase agnostic waveform. It doesn't matter what the timing is, it'll suppress pathological oscillations. And so what I'm going to show you here is, this is again our stimulus. This is the system's response. What we've done is taken 8 of these waves, have them all started at different phases. They're all acting independent to each other. And then we're going to be giving a stimulus, and we're hoping that we'll be able to suppress all 8 of these pathological oscillations. These 3 plots here essentially are the same plots, just in different views and different perspectives. All of these waves are again rotating around a ring. And what I've done in this plot is just to cut one side of it and then just kind of unwrap it out over here. This is just a top-down view where we're pushing out all the action potentials along the side. But what you'll see is we've generated a waveform that is slowly suppressing all the different waves. And this was a really exciting finding for us, because we had the assumption that you have to have phase specificity all the time. And so this waveform showed that there is a possibility, if we didn't know the phase, we may still be able to develop treatments that would successfully work for these patients, even if this wasn't a known, we couldn't get the timing right. Now, the energy for these solutions are still higher than if we knew what the phase was and if we could time it specifically. But there are instances in a clinical setting where we might not be able to get the right phase, or the phase changes and there's noise in the system. And so to be able to then suppress pathological behavior with solutions that work regardless of the timing of it, opens up a window of opportunity for us to be able to develop therapeutics using electricity in ways that were originally we weren't able to do so, we weren't able to do before. And so this is kind of where we're really, this is what we're exploring a lot of right now. How do we continue to then apply a lot of these things, not just in computer simulations, but apply it starting in animal models, in more complex systems. And actually, more accurately, how do we understand what's going on here? Because while we have this really cool waveform here, what does this waveform mean? What is it telling us about some of the underlying mechanisms? And then can we leverage our understanding of those mechanisms to then better develop tools and therapies for the future? And so this is kind of where a lot of a lot of the interesting work that we're doing is going, and we're in the process of starting to look at hardware and how do we implement this into devices and animal models soon. And so I want to thank this work I've only been able to do this with the help of many people, and so I want to acknowledge Dr. David Pedafar, Sarah Hackett, Imran Kalhoro, and Varun Sridhar, who have blessed me in many ways through this project. Dell Medical School and the Odin Institute have been extremely helpful, and our funding sources from the Clayton Foundation for Research and the NIH have been extremely welcomed, and we are very lucky to have them. All right, so I'm very privileged to have two really cool people join me now. Dr. Audrey Brumbeck is a neurologist, a pediatric neurologist at Dell Medical School and at Dell Children's Hospital. She does a lot of really cool research and sees a lot of really interesting patients. And so I'm very fortunate to have her as part of this panel today to provide the clinical and the neuroscientist perspective. Dr. Jose Milan is a professor of electrical and computer engineering here at UT, as well as a professor in neurology at Dell Medical School. And He does some really interesting work with brain-machine interfaces, the interface development of hardware between the brain and computers. And so I'm really fortunate to have both of them join me here, and we'll take questions. So we have one question from Joe. They ask, when electrical treatments are used, how long does the treatment typically stay useful? Are there any issues with several uses? Audrey, do you want to, as a clinician, do you want to take a first crack at this?
Yeah, sure. Great talk, Joshua. I always learn so much when I hear you talk about your work. So when electric treatments are used, how long does it typically stay useful? Well, I think we're really learning this. I think that many of the treatments that are currently using electrical stimulation, are deep brain stimulation, where we have an electrode living in the brain, constantly. And so I think that that's really sort of an outstanding question of, could we provide, sort of like Joshua was saying, sort of like a one-time, just the right one-time thing that would allow us to switch between one type of brain activity and another type of brain activity. So we wouldn't need sort of that ongoing, stimulation. And so, Joe, it's a great question. I don't think we have the answer right now. Jose, I'll be really curious to hear, your thoughts on this. You're muted.
I was muted. So, Joshua, great talk. Thank you for introducing us to this fascinating field. So yes, we don't know for how long these treatments will last. As Audrey said, most of these cases require a live stimulation. This is the case of the brain stimulation for Parkinsonian and other disorders. The key question will be, how can we minimize energy so that we don't need to continuously stimulate? And the other is for other disorders, mostly cognitive disorders, could we have a limited intervention that will last eventually for weeks, months, even for the rest of the life? So this is a frontier area of research. We don't know much, but definitely we are here at UT also exploring.
It's interesting when I think about sort of the parallels with pharmaceuticals. For some pharmaceutical interventions, they're time limited. Like if I have an infection, I take some antibiotics and then it's gone. But I think for most of these disorders that we're talking about, even the pharmacological therapies that we're currently using, it's really rare. I can't think of any instances where it's sort of a one-time thing and then you're good. So I think it's an interesting question, both from like the electroceutical standpoint, but also just from a general, how are we developing treatments at all? Whether it's pharmaceutical or electroceutical.
Yeah. Well, if I may add, I was saying this is a frontier area of research, but eventually one of the key things that the electroceuticals can bring to the brain health is the possibility to induce plasticity. And if it is true that we can induce the right plasticity on the right place in the brain, then this means that we can recover the correct functioning of that part of the brain, of that network of the brain. So there is the possibility to have a limited time intervention that will last way longer. Is that a dream? Maybe, but we need to pursue dreams, isn't it?
I think that's a really good point, Jose, too, because everything I've talked about so far, when we think about optimizing waveforms, we're thinking about optimizing it for energy purposes or for the instantaneous outcome. But what if we reframe that question? So we're optimizing it for long-term plasticity or long-term changes. Can we, maybe we are trading a little bit of extra energy now for less energy down the future, because we're, as you're saying, we're creating plasticity that's then allowing the body to take on more of the burden later on, by changing some of that now. So one of the things that's really fascinating for me about just optimization in general is how important the question you're asking is, and by changing those questions, we can think about how do we optimize along different parameters than what we would have originally thought was optimal.
I think that one of the most interesting parts of of this whole field is that idea of immediate feedback, that we can both be recording the electrical information and then providing a stimulus. And I think, Jose, your work, I think, is really with brain computer interfaces is really at the forefront of this. I was wondering if you could just comment on that aspect of things.
Well, this is clearly one of the areas where eventually everything can come together, and eventually I would like also to say that we cannot put a dichotomy between classical drug-based therapies and electroceutical therapies. Most probably, if we want to have a true impact on brain health, we will need a mixture of everything. And which is that mixture? We don't know yet. Again, we are in this exploration phase. But in any case, yes, Joshua was making it very clear. Stimulation at the right time, phase, amplitude is key, because it suffices to be slightly out of sync with that magical moment, that sweet spot, that consequences can be dramatic. So this means that we need to have mechanisms of recording, monitoring, acting, and checking that the effects are the proper effects. And this is where brain-machine interfaces, brain-computer interfaces come into play in this new field.
Yeah, actually, to add to that, there's a question here about the use of control loop systems and whether they would be more effective than deep brain stimulation. And so, Jose, I'll turn this over to you. Your thoughts on the use of control loops and how they could play into the future of.
Well, we and others have shown that, in fact, when you have this control loop, because you are monitoring the state of the area where you are stimulating for Parkinsonians, for example, we did this work a few years ago. If you do it at the right time, because you have a model that says this is pathological, we need to change it, and then at that moment you stimulate, first you have the same effects in terms of alleviating the symptoms that this patient, Parkinsonian patient, has at that moment, tremor, rigidity, all those classical symptoms. You are consuming way less energy. And interestingly, over time, the system has to stimulate less and less and less and less. So we never explore the ultimate use of weeks, months after of this. We call it closed loop, controlling the state of the network, stimulating when needed, and continue to monitor. But if it is true that we were observing over the course of days less and less and less stimulation, can we even stop it altogether? I don't think.
Yeah.
But
I think it's an interesting idea to explore. And the other thing I would add is that the closed loop doesn't just only have to be the timing of it. With a lot of the stuff we're doing, does the waveform itself change as well as we're iterating? And can we even develop? Because I keep thinking there was this patient that I had met that had a spinal cord stimulator because he had chronic back pain. And for the first 6 to 8 months, it worked really well for this patient. But then over time, the efficacy of that device slowly got worse and worse. And he was pretty old, and doing surgery to just move the electrodes or reconstruct everything would be a very big investment, and not just in terms of finances, but in terms of his health as well. And so I've always wondered if we were able to change the waveforms and have it constantly learn from these individuals, could we adapt the waveform to adapt? It's interesting because it's this game of kind of, you know, two things chasing each other over and over again, because the body is going to be adapting to these electrical stimulation, but then can the electrical stimulation also be adapting to what the body is responding to in order to kind of continually optimize these things over time? Yeah, I mean, all of this is just kind of really cool to think about what the future could hold for electrical stimulation and you know, brain computer interfaces.
I think, you know, in some of the questions, so Bernadine's asking, you know, could it be a possibility for this treatment to be used in place of medications for issues like depression, anxiety? And in that case, you know, the future is now. I mean, it is FDA approved to use a non-invasive stimulation technique called transcranial magnetic stimulation, or TMS, where you really take a wand and hold it up next to your scalp and provide through the skull a magnetic field that influences the activity of that brain area that's right under the skull. And that's being used to treat depression today. And I think it's a really active area of research. You know, what are the other disorders we could be treating with this? My specialty is autism, and my field of research is really to try to identify, you know, where we should be stimulating to treat autism-related symptoms. Because we don't quite know that yet. And so kind of as the technologies advance through my colleagues here, you know, I can sort of be mapping out the circuits, and we can meet in the middle once we know kind of where to stimulate and how to stimulate and do it safely. Then we can provide some treatments for our patients.
There is some really interesting studies that have also been done with deep brain stimulation for depression. I'm not sure about anxiety, but I know obsessive compulsive disorder, major depressive disorder, there's a lot of interesting research that's being done in this area. And I had a really good conversation with a professor of psychiatry about some of these new developments. And one of the things that they mentioned were, at least with patients that are depressive, there is a electrical change that can happen. And patients do say that they feel their mood just lift when the stimulators are turned on. But you can't leave the stimulator on perpetually. And then what happens is, although their mood lifts, there are still behavioral patterns that have not yet kind of adjusted as well. And so there are behavioral patterns that kind of bring them back into depression. And so this is one of the really interesting areas where, like Jose had mentioned previously, these electrical treatments can't operate really just by themselves or in a silo. They really work best when we put them in conjunction with a lot of these other methods. And so when we're talking psychiatry, how do we incorporate electrical stimulation perhaps into our use of you know, pharmaceutical therapies, talk therapy, counseling? And so how do we help our patients, you know, kind of in a very holistic way, where electroceuticals is one tool in our toolbox to ultimately get them better through this process.
Mm-hmm.
And then there was another question I think that I saw. Yeah, so Brad asked, do you work with or know of any non-invasive or contact-based modalities for treatment? And like Audrey, you had mentioned, you know, using transcranial magnetic stimulation. I've heard there's some really interesting work. I don't know if either of you have heard or used it, but using fine ultrasound to get more precision with the stimulation. I don't know if either of you can talk about experiences with those.
I think for any of this, really what we're talking about is, you know, ways of providing energy, you know, to biological tissue. And yeah, ultrasound is one way that is being explored to do that. I'm familiar with the work in rodents, in mice, where people are basically able to stimulate areas deep in the brain without affecting the the more shallow parts of the brain, and to get some to basically to be able to non-invasively stimulate areas that aren't sort of available. They aren't right at the surface that you could get with your magnetic wand. And so I don't know if there are any current clinical trials in humans for that, but I think it's a really exciting area of research. Jose, what do you have to say about it?
There is I don't know whether they have already started or it is about to start here at UT Austin, a clinical trial with humans using this ultrasound, focus ultrasound it is called.
Oh, that's
and they have shown that in healthy individuals first, that when they apply this focal ultrasound on a very particular area that is suspected to be the area that is malfunctioning in certain psychiatric disorders, they can change the activity of that area. So the hope now is, if it is true that the brain is the causal cause of our behavior, by regulating properly the activity of that area of the brain, then behavior will change. So they show that indeed by applying this ultrasound, the activity in the area in healthy individuals change as they want it. Now they are about to launch, or they have already started this clinical trial. So very exciting times.
That's amazing.
Oh, that's very cool. There's another question here about comparing what parameters make the use of electrical deep brain stimulation more appealing than some of these other neurostim methods. Audrey, I guess from a clinical perspective, Audrey, do you have any thoughts on this?
Well, I think that with deep brain stimulation, you're really targeting this, you're physically putting your stimulating electrode, in the spot where we think the trouble is coming from. And so, for instance, with for epilepsy, for focal epilepsy, where there's a little part of the brain that's hyperexcitable, to really be able to put your sensor and put your stimulator in that physical spot, I think is really attractive, because that you're actually targeting that specific region. But I think that the challenge is that sometimes, well, maybe you don't just have one spot, maybe you've got 3 spots, and so then how many electrodes are you really going to put in? And so then it sort of gets to gosh, maybe we should look at non-invasive ways of doing this. I think the other thing is, in order to get to a spot in the brain, you have to go through brain. And so, making sure that any sort of injury that's happening in the tract that you're, pushing through to get to your spot of interest, that you're not, injuring, your memory of high school prom or something, that it's that we're doing more good than harm. So I think that's definitely a cost benefit ratio that we're always thinking about.
Jose, I guess from an engineering perspective, what's the level of precision that we can get with non-invasive stimulation?
Well, with non-invasive, clearly we cannot have a high spatial resolution. What do I mean by a spatial resolution? Is that we cannot target a specific small area of the brain when we are injecting currents from outside. These currents will spread and will go beyond the area that is being our goal. Having said that, there are techniques where you can stimulate not only at one single point, but at several points with very small currents, so that all of them converge on a single point. And there it is where we are targeting, of course, and where the effects will be maximized. Now, Audrey already mentioned that being non-invasive means that we cannot penetrate too deep into the brain, because otherwise we will need to have very strong currents, and then we will be causing more harm than good. So there are limitations clearly to non-invasive approaches. But still, that there are many conditions that we know that are regulated by our cortical areas that are just the surface of our brain, so that it will be easier to intervene non-invasively.
I think
And now, which are the parameters? And this is very interesting. This is again open research. Joshua, you were mentioning that sometimes it is not simply the moment. It is you need to be even more precise. It is the phase of the signal. So the phase of the signal is it is at the very bottom. It is at the very top. It is that frequency, it is that other frequency that we need to target. So all these specific elements will change the effects of our intervention. And the other thing is the patterns at which you show that very nicely. The different patterns will have different effects, and most patterns will not have any effect.
I think one sort of contrast to this, the conversation about kind of, hyperacute, precision timing is the case of vagal nerve stimulation, where we take an electrode and place it on the vagus nerve, which is in the neck and projects up into the brain, but it's non-invasive in the sense that it's just out here. You don't have to drill through the skull. But that stimulation is very interesting. It's used primarily to treat epilepsy. And what we see is that, you might get some benefit, right away when you turn it on, but really the main benefit comes months later. And so we think that there's sort of a slower process that's going on where, the sort of, we call them neuromodulators, sort of the other chemicals in the brain that kind of have the more slower, but maybe more global effects on how, individual neurons function. That's kind of the system that we're modulating. And so I think that's also, I think we can learn a lot from that in terms of other brain systems that we could be stimulating, the dopamine system, the serotonin system, targeting sort of specific neuromodulatory systems that could maybe obviate the need for hyper precision. If we're sort of able to increase the tone of serotonin, for instance. And we do that pharmacologically with SSRIs, the selective serotonin reuptake inhibitors. So Prozac or fluoxetine is the generic name that basically, when serotonin is released from one cell onto the other, there's always some that's kind of left hanging around. And there are some transporters that suck it up and bring it back into the cell and repurpose it so that it can be used again. And the drugs that are the SSRIs basically block those transporters so that more of that serotonin kind of hangs around and is able to exert its effect for a longer period of time. And so I think that, kind of thinking about how we could use electroceutical strategies to, get kind of similar benefits that are maybe longer, over longer time periods, is sort of an interesting alternate universe of electroceuticals, beyond sort of the precise, needing to stimulate things at the exact right phase.
Yeah, to actually add to that, I think in some of the literature that I've seen with epilepsy specifically, even though they're not getting 100% suppression of seizures whenever they occur, they are noticing over time for some patients that the number of seizure events is decreasing. And so like you're saying, that there is, we're still learning what the mechanism of this is, or why is it doing this, but there is a short-term and a long-term component that we're observing, we're starting to see now, and trying to, again, understand why that's the case. And I like how that ties in with, Jose, what you're saying with plasticity, because if we can understand some of the mechanisms, can we actually target that mechanism a little bit more precisely, and hopefully have longer term benefits as opposed to these things being kind of accidental findings.
One thing I wanted to ask about was the idea of combining non-invasive stimulation with methods that would allow us some more selectivity. And so I'm thinking about in my world, I use an approach called optogenetics, which is where we use light to selectively activate or inactivate specific populations of neurons. And we do that by basically inserting in the neuron's membrane, we insert these ion channels, just like the ones Joshua showed, that pass the sodium or pass the potassium and make the basically is the currency of that electrical charge. We put these channels in the membranes that are light sensitive. And so when you shine light, that channel opens and then those ions rush across the membrane and you get the cell activating. Or conversely, you can have it pass the other type of current and make the cell quieter. But that approach, which is was one of the first discoverers of that was Boris Zemmelman here at UT Austin. And it was really sort of expanded upon by Carl Deisseroth and colleagues. That's been really revolutionary for neuroscience, for us to be able to selectively put these ion channels in particular neuron populations so that we can then activate those or silence those and say, well, what happens, was this population of cells necessary for, whatever the behavior is that we're interested in. And so I think on sort of the basic neuroscience side, we have this luxurious, ability to really precisely target our neurons. And I think that one of the big questions now is how do we get that specificity in a non-invasive way? And so, I think that some of the things I sort of dream about, about sort of sci-fi versions of things is, being able to inject something that would track to a particular populations of neurons and would sort of make them more susceptible to the magnetic, wand that we're holding over the head. Or I'm curious if you guys are sort of familiar with any of the kind of, emerging technologies that are going to enhance the way that we do non-invasive stimulation.
Not that I know yet.
Yeah.
There are explorations on optical mechanisms, but this requires projecting laser light that goes through the skull. At the end, the question will be always the same. How selective are you in targeting that area, and not only that area, that type of population of neurons? Clearly, this is a big challenge. But if humans are known for something, they preserve and they find solutions. So
there's something I didn't talk about in the presentation. We found the optimal waveform for a single neuron. So the model that we showed, we were able to show that the rectangular pulse for just one neuron isn't a rectangle. It's actually there's a negative pulse that's kind of normal looking, and then there's a positive pulse. And as there's been work done to kind of explore why that's the case. And one of the really interesting findings was that that particular stimulus leverages the timing of how the sodium channels open and how the potassium channels open. And it navigates that in such a way where it takes advantage of those particular timings to then selectively cause just the bare minimum energy necessary to have that neuron fire. And one of the thoughts that we've been thinking about in the, Dr. Peter and I have been thinking about is just given the fact that different types of neurons have different types of channels with their own unique timings, are there ways that we can shape the waveform so that it's taking advantage of these intrinsic properties of these neurons to then selectively stimulate just a particular class of neurons because they have these specific channels? So including what you're saying with the optogenetics, which is really interesting field, right? Like if we were able to design channels that we knew the time constants, how quickly they open, how quickly they close, could we design waveforms that would then target just those and not any of the other ones, just by changing the shape of the stimulus? And I mean, to just kind of riff off a little bit from that, even in the field of like retinal prosthetics, right? Like for patients that have some kind of disease of the retina, there is technology out there, and I believe it's actually been FDA approved as well, where they can put an electrode array on the retina and feed in information from a camera external to the patient. And that those signals will then go into the retinal array, the electrode array, and then feed pulses to the optic nerve behind it. And so therefore, you can have someone that's blind see just through this camera and electrode array, which is mind-boggling how cool that is, right? Like helping people that are blind being able to see is just really cool. But as of right now, the technology for that is still kind of relatively new. And the last I heard, I think people are able to get about 48 pixels worth of information. And so you can see enough to see the outline of the door or see like, the crosswalk on the street, for instance. But it's very limited. And one of the things that, as I've been digging more into this, we realized is that these are still kind of general pulses that are being given. And there's about 20 different types of retinal ganglion cells in the body. And so when you stimulate one, you're stimulating almost every one of them. And so it's very indiscriminate in how it's stimulating. And so could we use waveforms to very fine-tunedly select which retinal ganglion cells we're trying to stimulate? And kind of, analogous to selectively stimulating based on channel designs and so on and so forth. But could we just by changing the shape of it and create more interesting, complex dynamics and waveforms and specificity of stimulation?
Yeah, I wonder, it would be interesting to sort of cross-pollinate with the cochlear implant world,
right?
Since we have, probably decades of experience there, with refining that technology. I bet there's a lot to be learned by the other sensory modalities that we're using for prosthetics for.
Yeah, absolutely.
I was looking, so
since I teach a course on neural engineering, and these are topics that we cover in the course, and we are engineers. We believe that we can engineer the world, and if we can engineer the world, we can engineer the human. And I always tell the students the key for people to recover partially vision, we are very far to provide them back even a kind of vision that is considered not to be or to be below the blindness level. So they can perceive, but clearly they cannot see. We are very far from enabling people to hear normally through cochlear implants. So which is the secret? And the secret is that the person who receives these implants have to relearn how to interpret those signals, because at the very beginning, those signals are pure noise. It is terrible, their experience, when they start receiving the first stimulations. And magically, within days, within hours actually, their brain learns how to interpret those signals. So we need to give credit to the major player in this business, that is the brain and not the technology.
Yeah, no, that's a really good point, Jose.
there was a question in the chat about diabetic neuropathy, and could we use these sorts of approaches for for peripheral nervous system issues? And I think the answer is yes. I was just looking that this is an active area of research for using electrical stimulation as an adjunct treatment for painful sensory neuropathy. So yeah, absolutely. This is not just good for your brain, it's good for your peripheral nervous system as well.
There was another question also about its use for ADD or ADHD. And the same thing as what we're seeing with diabetic neuropathy. There's a lot of interesting research that's trying to see, can electroceuticals be useful for these things? So there are studies right now that are being done for ADD, ADHD. A lot of these things, the challenge is that we don't have a good sense again yet of what the mechanism is. What are we supposed to be stimulating? What are we targeting? And what are the measurable outcomes? So what is it that we're looking to see change in the body? And like, say we take depression, for instance, or some of these psychiatric disorders, these may have really long time steps or time constants. And so while we give a stimulus now, we might not see immediate results, or it might be some time before we start seeing results. So then how do we kind of close the loop in these instances where we might not always be able to tie instantaneous outcome or immediate outcomes to the stimulus that we're being given, that are being given? And so this is definitely, as has been said, this is an area of active research. People are still trying to find out what are the appropriate biomarkers, for instance, and can we use biomarkers as a surrogate for seeing people improving in ADHD, ADD. There is some work being done with Alzheimer's that's also being explored right now. And again, people are using, like, for instance, the tau protein or some of these biomarkers as surrogates to see if we can slow the progression of Alzheimer's. But this is, again, a very active area of research, and hopefully as time continues, we'll see some really cool stuff come out from all of this.
I was going to say that, we're the idea of a biomarker, I think, is really sort of, complementary to this idea of, developing treatments, because, we have to have a way of monitoring treatment, and that can either be by how somebody tells you how they feel, or, by, looking at some part of their body, or by measuring a blood level of something, or measuring the electrical activity of, their heart or their brain. And so, for disorders like, diabetes, we have got great blood tests for that. We're really good at telling if you've got diabetes based on, a little sample of blood. But for disorders like ADHD, for autism, depression, basically any of these disorders that are, kind of neuropsychiatric or neurodevelopmental, we don't have good biomarkers for those. And so I think for me, that's one of the most exciting areas of research is developing, especially the electrical biomarkers. So like the EEG biomarkers, because those really tell you, about, current brain functioning. And I think that, to be able to, have that readout, not only for, being able to diagnose and to, sort of stratify people and predict, how severe things will be in the future. But I think for this specific topic of conversation, the idea of developing treatments, I think that it is really critical that we have that kind of readout. And I think that one nice thing is that, these, like the squiggles that Joshua showed you on the screen of EEG in humans, monkeys, mice, rats, like we all have the same squiggles and they all kind of mean the same thing. There's certain sort of, frequencies of waves that we find in humans and in mice. And even though our brains are, hugely different sizes, our neurons are kind of all oscillating at similar frequencies. And so I think that's great, because that means that the work that we're doing on the basic science side has a large potential to be able to translate into humans. And then back translate, to be able to take things that we're understanding about how humans, how human electrical brain activity works, and then go ask the questions, in the laboratory to find out, well, what channel is that that's causing that? And maybe I could, if I could figure out the channel, I could tell Joshua to, stimulate it this, with this type of waveform. So I think it's real, that idea of biomarkers is very exciting.
There's this interesting question here about using these types of algorithms and changing the stimulus to as a diagnostic tool. So kind of flipping the question, so and not just using it as a therapy, but can we use it to learn more, gain more insight?
I think on the research.
Any thought? Yes, go ahead.
Yeah. I was going to say on the research side, I mean, I think people are using transcranial magnetic stimulation for that purpose. People who have, this brain condition will respond to a stimulus in a different way. If you measure sort of the EEG readout of the changes that happen after you give that stimulus, we can see that people whose brains work in one way, respond in one way and compared to others. But then I also think that, we do that actually already with EEG when we're measuring for people who have epilepsy. We already sort of provide stimuli and see how the brain responds. We do that by either flashing lights at different frequencies. And we see that the brain responds to those frequencies. We call it the photic driving response. And that really tells us a lot about how the brain is functioning. Another sort of interesting thing that we do is we make somebody hyperventilate. So we have them, blow on a pinwheel until they feel lightheaded. And the way that the brain responds to that also tells us a lot about how the brain is working. And so, so we sort of have our natural inputs, to the brain through our eyes and ears and such, that we can use to stimulate the brain. But then also, we can also just, put a magnet.
Jose, have you had experience with potentially changing the way we interrogate a system, for instance, to learn more about the system itself?
No,
as an engineer.
I don't, but definitely this is a very interesting question. If we know a little bit about what is a pathological condition and what it is not a pathological condition, in terms of the signatures of the activity of the brain, how can we, with brief stimuli, external, internal, generate can we, for example, observe whether the speed at which certain pathological rhythms start building up that will allow us to understand the severity of the situation, how the spread of the damage in a certain area? That would be very, very appealing. But of course, whenever we do that, we need to have also the tool to stop it. We don't want that to spread. But normally,
Right.
This is the case, because if we know which are the waveform that will generate only the onset but not the spread, that would be sufficient. And this is where you come into play. You're sure.
Yeah. The other aspect that we've been thinking about is whether or not these optimal stimulus waveforms could give us insight into how well our mathematical models or our simulations match human data. And so could we optimize waveforms to try to see where do these models and real systems start diverging, and then help us realize that this is an area of our model that we need to further improve or further develop. But this may also give us insight into how do we better understand, I'm the kind of person that likes to build to make sure I understand something. And so if I can't build it, or if it doesn't match what's really there, then we realize that there's a deficit in our knowledge of the system. So could we kind of take the engineering side and bring it back to inform the science side to build better models or more accurate representations that can then be used for in silico experimentation for patient-specific testing down the line?
Definitely.
Hey guys, I gotta be honest, I could sit and listen to this all night, but you've been going for a while. You're probably getting a little tired. So how about if we unfortunately wrap things up? And so we're gonna play a little game that we always play, which is we call lightning round. So give it a little bit of a thought, but give us a 30 or 45-second comment on something that you wished we'd talk about tonight but didn't, or something you'd like to emphasize on the way out.
Well, let me start. I think that we have touched many things. I don't think that we have let anything out. Probably yes, but not something that I can think of. In any case, I think that something that is fascinating is the possibility to bring together multi-perspective and this idea of closed loop, control loops that require first to identify which is the target state of that region of the brain that we will like the brain to be. And now to monitor in real time that state, how we need to stimulate to bring it closer, to push it away if it is a pathological condition. This is fascinating. And if we then have the possibility to induce plasticity so that the brain itself, so I like to say how we can help the brain help itself by inducing plasticity that will avoid then the use of any other external intervention. That's the ultimate dream.
I can go next. So, I'm in the autism field, and right now, there's a lot of discussion about neurodiversity and, how much should we be trying to change people's brains? Why isn't it just that we change our society and become more enlightened and include people whose brains don't work, the way that most people's do? And so I would just like to say that I think that, the type of work that I think and my colleagues here are doing is really to, is to help people who are having difficulties that sort of aren't amenable to kind of environmental changes, depression, difficulty processing information, these sorts of things that, I completely agree. I'm a big fan of neurodiversity, and I think we need to be more inclusive in our society. But I do think that, the idea here is really to help people who are having difficulties and treat those specific things that people want help with.
I think for me, the biggest thing as I've been having this conversation and doing this research is just how little we still know and how we're not even asking the right questions sometimes. I love, Jose, what you're talking about with plasticity, because so often I think, at least in the work that I've done, I'm focused often on how do I get the immediate transition, or how do I get the immediate state change, or how do I help this patient feel better right now. But we sometimes lose sight of the fact that there is a longer term picture, there's bigger picture. And so even when we're trying to optimize things, that question of what is it that we're optimizing and whether we're optimizing the right things is a big piece of all of this. And I think it's something that I've been challenged myself in my research, that sometimes we're optimizing the right things and then realize down the line that, oh, actually our algorithms optimized it exactly as we wanted, but that was the wrong question we were asking. And so this is something that I think is very humbling and but also really exciting to be thinking about as we go forward.
Amen.
Well, thank you, folks. This is the most unsatisfying aspect of the remote format, is that you guys should be in front of an audience getting a huge round of applause right now. And so I want you to imagine that's happening, because that's what would be happening if things are different. So thank you so much. And thank you, Dr. Audrey Brombach. Thank you, Dr. Jose Milan. Awesome panelists, and particularly thank you, Dr. Joshua Chang. You guys did great. Thank you so much. Yay. And I want to thank the audience for hanging in there. Just a barrage of outstanding questions. Thank you. And just to remind you, there's more Brainstorms on the way, including a 6th season starting in August. And we hope to see you next time. Thank you so much. Don't forget to go to utbrainstorms.com for all the information, and the UT Brainstorms channel on YouTube for all. We have videos of all but 3 brainstorms over the last 5 years. So thank you so much, guys. Outstanding job. See you next time.
Bye. It has been a pleasure, Mike.